Thank you. So I'm working on sharing my screen here. All right, and that's working well. Yeah, thank you for having me today. So today we're going to talk about the comorbidity of mental illness and intellectual disability, and kind of that dual diagnosis. And then also, I was asked to talk a little bit about Ohio's Coordinating Center of Excellence in Mental Illness and Intellectual Disability. So we'll talk about some of those things. I'm open to any questions or anything that anybody has. So I wanted to talk about intellectual disability first. So there's an estimated 10 to 15 out of every 1,000 children in developed countries that have an intellectual disability. So that's about 1 to 3% of the population in Western societies. And it's a little common more common among males. Children and adults with intellectual disability are a little bit more at risk than the general population to have a psychiatric disorder as well. So that's kind of why we're talking about this today. So it's even up to 2/3 of people with an intellectual disability have a diagnosable psychiatric condition, including almost 50% of children. So with mild intellectual disability, there is an increased risk for conduct and behavior disorders. There's also an increased risk, especially in mild ID, of negative self-image, low self-esteem, poor frustration tolerance, and sort of a rigid problem-solving style. So you can see how that would connect to mental illness or behavioral symptoms. In severe intellectual disability, there's an increased risk for autism spectrum disorder. And sort of across the board, we see more symptoms of hyperactivity, shorter attention span, and self-injurious behaviors. Up to 50% of the population with intellectual disability have meet criteria for a mood disorder. That's more like 10 to 15% of the general population. And then 2 to 3% meet criteria for schizophrenia. And in the general population, that's more like 0.5% to 1%. So a significantly increased risk there. There are lots of different causes of intellectual disability. They can be genetic, it can be developmental. Something happens, while the baby's developing in the womb. Can also be environmental, like trauma to the mom, or mom being deprived of certain resources, or it can be a combination of these things. There are some syndromes that we associate with sort of specific mental illness or behavioral symptoms. So I just listed a few here. For example, Fragile X syndrome. There's a high comorbidity of ADHD and autism spectrum disorder. For people with Down syndrome, there are potentially more social and emotional difficulties, even psychotic disorders and early onset Alzheimer's. Fetal alcohol syndrome, we know there's an increased risk of learning disorders and ADHD. So when we're thinking about assessments, we're thinking about all of these kind of specific risks that certain people may have. And that's why we might recommend certain types of assessments or something. And there are certainly other factors after birth that can contribute both to developmental difficulties and psychiatric disorders. So things like head traumas from accidents could contribute to intellectual disability and then behavioral symptoms. And certainly deprivation of any kind, abuse of any kind, can put the child at a greater risk for both developmental problems and things like PTSD, ADHD, anxiety. So those are the kinds of things we're looking at. It definitely is important to remember that while there is an increased risk of psychiatric disorder in the population with intellectual disability, not every behavioral symptom we see is caused by a psychiatric illness. I know I have talked before, and others talk about things like pain or difficulty communicating can really contribute to behavioral symptoms. So we're going to look for things like constipation, headaches, tooth pain. I had a patient one time that we couldn't do anything about the aggression with any psychiatric medication we tried, any behavioral measure we tried. But as soon as he had a root canal, things were fine. So to talk a little bit about the Coordinating Center of Excellence in Mental Illness and Intellectual Disability. This was a project initiated in 2004, and it is dually funded by the Department of Developmental Disabilities and the Department of Mental Health and Addiction Services. So the mission is to make life better for people with dual diagnosis of mental illness and developmental disability. There are expert assessments and recommendations provided. There's training and education. We're actually working on sort of a repository of training videos or educational videos that will be available on the website. And I can share the website in our email afterwards. And then the goal is for kind of the mental health world and the developmental disability world to work together to build resources and community and knowledge for people with a dual diagnosis. So we'll kind of talk about those things. There are dual diagnosis intervention teams that have been developed. So these are teams of 8 to 12 people from both the mental health world and the intellectual disability world that currently cover about 60 counties in Ohio. And they can be of kind of extra help if somebody is struggling to get the services they need. They can be a good resource for teams that are trying to find resources and extra services. I talked about the education piece a little bit already that we're working on. And we will talk about kind of second opinion assessments and also kind of ongoing care. So one of the sites that ongoing care is provided is the Montgomery County Board of Developmental Disabilities. That's where Wright State is located in Montgomery County. Well, Wright State, our department was located actually in Montgomery County, but Wright State, I guess, is in Greene County. But so this is a collaboration between the Montgomery County Board of DD and the ADAMS Board. And they provide face-to-face psychiatry. There are 3 faculty partners and 4 resident physicians, and there are lots of services offered at this site to about 300 participants, typically face-to-face. Although we'll talk about the telepsychiatry project, and in the last year we've all experienced a lot of telemedicine. So the telepsychiatry project was formed in 2012 after kind of some of the initial lessons from the CCOE in general. It was noticed that obviously in rural communities, there are fewer providers for specialty care. So this was a way then, and now as we talked about, we're used to this telemedicine model. But this was a way to provide more specialty care with people not having to drive so far for services or just skipping services altogether. It also can help psychiatrists collaborate with others who are providing the care in these communities. So we definitely have seen that it reduces travel time, costs, ER visits, and hospitalizations. And the model is for our case managers and nurses to really touch base with the teams and the families to make it easy for people. So they make sure the technology is working, they test the software, it's easily downloadable. And it provides much better access to more care for individuals and families. They can touch base with nurses in between appointments and those kinds of things. So as of June 2021, over 1,700 individuals in Ohio were participating in this project from 85 counties. And we certainly prioritize people who have been discharged or are in developmental centers and in state psychiatric hospitals. So the county board will arrange staffing and computer equipment, make sure people have access to the internet or the technology they need. So some people or families may travel to the county board to have their appointments. This can also be set up in schools or day programs and workshops, as long as there's a private area. And then the county board would also accept the lead role in coordinating access to emergency services. If I'm in Dayton seeing somebody, I don't know, what the emergency services are in a county that's pretty far away from me. So we do see people from all counties in Ohio. The top 13 populated counties, we tend to focus on children just because there are typically adult providers available. So just kind of a note on that. So these are the requirements for people who are eligible. And some stats about like hospitalizations. We definitely have seen a decrease in hospitalizations and ER visits in the 12 months before people become involved in these services and the 12 months after. No referrals are denied, even if it's from those 13 counties and people really think that an individual could benefit from services. Those referrals have not been denied. In the sake of time, I'm going to skip over some of these because we've talked about some of them already. So we've really learned that the mental health and developmental disability systems can coordinate and help each other develop ISPs and treatment plans and those kinds of things. And it really works better if we can all work together for that. So that's one of the goals of the CCOE. We really make each other stronger. So the second opinion assessments I wanted to talk about a little. We do about 100 or more of these annually. So these may be, a team or a physician or whoever has a question about diagnosis, has a question about this person is on a whole lot of meds. What can we do to decrease those or optimize those? Or we don't know what the best practices are for this person and what the best services are. What else do we need to get involved here? Or there are specific sort of behavioral concerns or potential mental health concerns that they're having trouble with. So we do these second opinion assessments and provide an expert evaluation. Those can be done either in person or via telemed. For the past year and a half, they've all been telemed. This is available anywhere in Ohio. And Dr. Gentili, I don't know how I'm doing on time, but Dr. Gentili has a great video on the CCOE website about how to prepare for a psychiatric appointment or a second opinion assessment. And it makes some great points about who needs to be at the appointment. It needs to be somebody who's knowledgeable about the history. Also the patient that we're talking about, I say patient because that's my role. but people who are knowledgeable in the team. And also it's really helpful to bring kind of specific questions or concerns to the appointment. And I will provide a link for that video as well, because I think it's really helpful and it's short. So the goal of the second opinion assessment is then to provide, this comprehensive evaluation and these comprehensive recommendations that also focus on trauma-informed care. We know that many individuals have had some trauma, big T or little t type trauma, and that trauma-informed care can really help move things in a better direction. So that's all I have, and I wanted to open it to questions or